We have a wonderful panel, and the panel members that are with us have their video cameras on. Everyone else, if you want to show your face, that is a wonderful way for our panel members to talk to someone and see your reaction. So please feel free to keep your cameras on. Of course, you're welcome for IT related issues. If you need to use to not have your camera on, that's also very okay. So we have an informal discussion. If anyone is interested in saying something, please keep yourself muted while you're not speaking. When you would like to speak, raise your hand so that our wonderful moderator knows that you would like to have an interaction. As I said, we are recording. We will also post this recording on the TBPPM Learning Network website for anyone to view back. We will also make sure that this is available on our YouTube channel, and so you can also see it there. Feel free to share it on any social media. Then I'm pleased to introduce our moderator for today, who is Mike Freak. He works for TAG as a co-director on the TB programs, and he coordinates several projects within TAG, including this important topic, the 146x24 campaign. Mike will be taking all the questions and moderating this full session, so I'm really pleased to hand over to Mike. And Mike, the microphone is yours from now on.
Awesome. Okay, thank you, Petra. Thanks, Joel, for organizing today's panel discussion. I'm really happy to be here. And thanks to everybody for joining. We have a great panel of 5 people who I will introduce shortly. We have Ronald from the Philippines, Michael from Kenya, Goodman from South Africa, Maggie from the USA, not too far from me, in New Jersey, New York area, and Kieri from India. So before I get to them and do kind of longer introductions and we get into the discussion, I wanted to give just a bit of preamble and kind of background to today's topic to kind of frame the conversation we're going to have and let you know what we'll be talking about. This is what we're calling the 146x24 campaign. And it starts from this realization that after years, decades really, of calling for, asking for, and working toward shorter, simpler ways to treat and prevent tuberculosis, we now have short course treatments recommended by WHO, backed by good science, good clinical trial data for nearly all forms of TB, TB infection, drug-sensitive TB, drug-resistant TB. It's kind of this amazing confluence. We could not have tried or planned if we had wanted to have shorter treatments for all kinds of TB arrive basically around the same time and enter WHO guidelines within the same, 1 to 2 year period. And so that's where the name of the campaign is coming from. The 1, the 4, the 6 are kind of marching down TB treatment, TB prevention for latent TB, taking preventive treatment. We can now do that in as short as 1 month with the 1 HP regimen, or once a week with the 12-week 3 HP regimen that you take just 1 day a week. So the 1 is for the prevention and it's 1 HP or 3 HP. The 4 is for drug-sensitive TB. We know that we can now treat and cure drug-sensitive TB in as little as 4 months using a novel regimen that puts together rifapentine and moxifloxacin together with 2 other drugs. We can also treat non-severe forms of TB in kids in as little as 4 months using the standard regimen that we have decades of experience with. And then the 6, of course, is drug-resistant TB, where we can use combinations of bedaquiline, pertomanid, linezolid, with or without moxifloxacin to treat and cure most forms of drug-resistant TB in 6 months, down from 24 months or 18 months of therapy. So like an amazing reduction. So we have these scientific advances. They've been taken up by the World Health Organization. They're in guidelines or soon to be in guidelines. And yet too few people have access to them. And we haven't really seen a lot of uptake or a kind of upsurge or groundswell in using these regimens and ensuring that they're accessible to everybody. So there's a sense of urgency here. And that's where the 24 and 146x24 comes from. The 1, the 4, the 6 refer to the treatment regimens and their duration that we're trying to make accessible. And the 24 sets the deadline. We want the conditions to make these regimens available to everybody to be in place no later than 2024. And we know that we have no time to lose because our targets set at the high-level meeting and ratified by our country governments for treating and preventing TB. We're behind on those. We were behind before COVID. We're even further behind with COVID. So we have a lot of ground to make up. We have no time to waste, and we really need to find ways to make shorter treatment available to people, whatever form of TB they have, wherever they live in the world. And that brings us to kind of what's at the heart of the campaign, which is this is really based on a kind of human rights idea that people have the right to benefit from scientific progress and its applications. And so with all the scientific progress in TB, how do we realize that human right? And how do we make these regimens available to people? So 146 by 24 is a campaign toward this direction. It's about treatment, obviously, but not treatment alone. We also need what Dr. Paul Farmer, the late Dr. Paul Farmer, called the staff, the stuff, the space, the systems, and crucially, the support, the patient support that enables treatment to be successful. So those are some of the things that we hope to talk about today under the banner of 146 by 24. And with that, I think I'm going to get into the questions themselves and jump right into it. The way I'm going to do this, just for those of you listening, is I'm going to introduce panelists as I ask them a question. So we'll kind of go panelist by panelist with questions and introductions, do that together rather than introduce everybody all at once. And let me start. I'm actually going to start with the panelist who's closest to me geographically. That's you, Maggie. You're in New Jersey, I'm in New York. So let's start at home, my home anyway. Maggie, you are a drug-resistant TB survivor. You're also a TB advocate from New Jersey. You have a background in economics and finance, and you work for the National TB Controllers Association here in the USA, providing community engagement and treatment support through a TB survivor group here called We Are TB. So my question for you, Maggie, is just thinking about the benefits of shorter regimens for TB. Why does this matter? What are some of those benefits? And tell us about the regimen you were on juxtaposed to what it could be with the regimen we have available today, if that had been available to you. So over to you.
Thank you so much, Mike. And yeah, I'm so glad to be here with everybody. So the shorter regimen for tuberculosis can definitely have a great benefit for patient, family, and even for the healthcare provider and health system. So that regimen that you want can help patient more easily to complete the treatment for TB compared to the one I was, because that one not only is like the short, 4 months period, that is like really short, compared to like a two-year period I was, and it wasn't really fun. And the availability of the shorter regimen enabled patients to be cured faster, also have the potential to reduce treatment cost. It's super expensive for the government. It also improve patient quality of life, increase also the completion of therapy, and reduce the development of drug resistance. So compared to what I went through, I had multiple allergic reactions along the 2-year process. I was isolated for almost 2 years, and it wasn't really a fun place to be. If that treatment was shorter, it would be able me to have less struggle as I have still today, going through long therapy every single week. And also, I think it's cost effective for the government, to be honest, because when a TB patient is healed, you have to ask your question, where does that money come from to take off that TB patient? So scale it like in a long period of time is a lot of money. So shorter the period of treatment really will help the government to save more money, but also to enable the patient and the healthcare system to have a better understanding of what's going on, especially in those areas where they do not have enough a possibility or enough infrastructure to take care of TB patients. I'm talking about like in Africa and all those countries in Southeast Asia. So this is definitely one of the solutions so far in order to just limit the effect of TB in the global scale.
Thanks. You gave us a lot of benefits from the personal, shorter periods of isolation and all the harms that come with that, to the kind of population level benefits, maybe advantages toward reducing development of drug-resistant TB if regimens are easier to complete for patients and easier to provide for health systems. And so the point you made about cost effectiveness and kind of the reason our health systems should be using these, we're definitely going to come back to those points. I wonder now, Goodman Makanda from South Africa, if you want to come in and give your kind of perspective on the benefits of shorter treatment, adding on to what Maggie just told us. Goodman, for those of you who don't know him, is a DRTB survivor as well, a passionate TB activist from Khayelitsha in Cape Town. He's also a member of the Community Research Advisors Group, which is the community advisory board to the TB Trials Consortium. I point that out because I coordinate that board, and we have other CRAG members on the line. I see Tina Shaw is here. And two of these things in 146 actually initially came out of some research done by the TB Trials Consortium. The once weekly 3-HP regimen was studied by TBTC, and the 4-month regimen for drug-sensitive TB was a TBTC study. So Goodman, I'm really happy to have you here, and over to you to talk to us about some of the benefits of shorter treatment from your perspective. And maybe I'll add a question onto this for you, which is, how do we start as communities advocating for this? Where's the place to begin? Okay.
Thank you very much. Everyone can hear me?
Yes.
Okay, thank you. Nice to join this panel. As you mentioned, I'm based in Cape Town. I'm an RTB survivor working for TB Proof. So what can I say for the shorter regimen? To second my colleague, yes, it will make easy for our patient, because to take a treatment for 2 years and a toxic treatment, so now it make it easy for them to finish earlier than before, because normally we having a loss to follow up, because people, they get tired of taking medication every day for 24 months. For extendedly for me, on my experience, I take it for 4 years, because I was from MDR-TB to become an XDR-TB. It was not an easy journey. And there's a lot of challenges when you are taking the treatment. All of those challenges are making our patient to run away from the treatment. So the shorter regimen, but we need to explain to them, where do we come from? We need those peer support to use those TB survivors to do sort of counseling for them. So we won't fail the treatment, the new regimen, so they can understand we're coming from the injection, we're coming from 24 tablets a day, but now we're talking about maybe for 6, like for people, it's for 6 tablets now people they are taking. So that is the benefit. Our patient, they can be finished early the treatment than to take many years to go and finishing the treatment. But now another question, how could we engage our community? How could we educate our community? I think WHO, before approving the guideline, and then the study has been done by certain NGOs, not by the Department of Health himself. So they need first to educate their healthcare facility, the people working in the facility, about this new regimen, because some of them, they are new on this betaquilin, new on this linezolid. They don't know what exactly to look for when we talk about the side effects. So we need firstly to get engaged with our healthcare facilities, educating our nurses and doctors what we're talking about, because I was also taking part to take this betaquilin and linezolid. I know from myself, I have experience to give out to people, they don't know what to do. So to engaging them, and then after that, we need to go out to the community, do sort of awareness to say, now we're having a new regimen. when it comes to TB, now you no longer, when you have an MDR or XDR taking for 24 months, now we're talking about 6 months, we talk about 9 months, all of those things. So the community, they are aware. The problem is when they reach the healthcare facility, they don't know they have a right to get a shorter regimen, or they have a right to get the long regimen. But the nurses should be also engaged and been trained. It's not everybody will fall on this shorter regimen. Some people, they will be taking this longer regimen because of 1, 2, 3, 4, you know, because if you're already having a problem with a liver failure, you can't be on these drugs. And so our community can be educated on this thing, because they will be fighting. Goodman was talking in the radio slot about a shorter regimen, but you telling me now I'm going to take so much months and so much tablets to cure my TB. So the benefit on all of this is our community, they're going to benefit. Beside our government, we must leave alone, because that is the rights our government to provide the medication for the community, because the slogan is, it's no community without government. It's no government without community. I think that makes sense.
Yeah, I mean, that is what you just ended on, the human rights, the whole thing about human rights, which is that people hold rights and governments are obligated to fulfill them. And it's about that relationship of the individual and their governments. And in the context of TB, it's about making these new benefits of science available. I like what you said. You know, we focused on shorter in the 146 so far and how we've described it, but it's also about, as you pointed out, tolerability, side effects, the pills people are expected to take, and treatment literacy, you know, sharing information, or what some people call demand creation. Whatever term you use, the goal is the same. When someone is diagnosed or goes to clinic, you want them to be able to say, I've heard about this 4-month regimen. Am I eligible for that thing? You know, are you offering me the best available thing? So let's bring in our third TB survivor panelist. We're really lucky to have a lot of TB survivors on the line with us today, both in the panel and in the audience. Kiari is an MDR TB survivor and TB activist from India, who's been very actively advocating for people-centered TB care and is a very active member of this TBPPM learning network. Kiari, I'm wondering, given your work on people-centered care, if you can talk about the part of the campaign I mentioned that we're calling the 5 S's, the staff, the stuff, the space, the systems, and that support, all those ingredients that enable treatment to be successful, to be about more than just taking medicine, and what that looks like in India, what some of the gaps are, and the opportunities to kind of improve it from your vantage point. Over to you. And I think you're on mute still. There we go.
Yeah, right now, gaps, what I hear from the TB patients which contact me through social media are like same, that they are not aware of what is going on with them. Like education is missing, like they are not aware about medicines. The way I heard about the shorter regime, and I wanted to attend this webinar because even I was not aware that this 4 months regime is like in place now. The same way when the people who are afflicted with TB, they are not aware of it. So it's like there should be somebody who should tell them that these things are available. Like they cannot, it's not like something which we as a patient know that this is available and you give us this. It's a people who are knowledgeable enough to know this medicine or this treatment, they should be spreading the message, and they should be telling, like they should be informing patients about it. So that is this education gap still there. It's like it will take still long time to connect, because most of the people, they don't know, and it is at such an epic scale that even the people who are treating, they don't have that kind of a time to sit and like tell them what is it and what is not. So other NGOs or other people, they have to take responsibility of spreading the word. Like the way I came to know from Twitter that this kind of code, this kind of regime is there, and I wanted to attend this webinar because of that, to learn more about it, because I personally don't know much about it. So that is how we can do and spread the word.
The education piece. being so
Yeah.
critical. You and Goodman have both spoken about that. And you're right. In the 146, I think we've heard the least about the 4. We've talked the least about the 4. And so that is really emerging as the place that maybe we're furthest behind on is 4-month treatment for drug-sensitive TB, but lots of ground to make up on the other 2 as well. Let's turn now, our other 2 panelists come from a perspective of having worked in TB programs, and so it'll be great to get their perspectives on this. Let's go first to you, Ronald. Ronald is currently a senior TB and Global Fund advisor at the Department of Health in the Philippines. And he has 15 years of experience in tuberculosis elimination programs. You've worked as a primary healthcare physician, a city NTP coordinator. So you've really seen TB at kind of all levels of government. And I'm wondering if you can talk to us, and feel free to focus on the 1, the 4, the 6, or any of these regimens that you would like, about how, from a programmatic perspective, would you start working on these? Are there issues that you think we need to overcome right away, or could we just hit the ground running? Like, what are some of the obstacles that we're going to have to anticipate for 1, 4, or 6 from the program side that kind of you're worried about initially? Thanks.
Yeah, thank you. Thank you, Mike. So whenever we have a transition to a new regimen, I think one of the concerns really for programs is the current stocks of old regimen drugs. That's a very common concern because under the program, we usually procure from 6 to 1 year supply. And so it happens that when we have new drugs and new regimens, that's a big concern. What do we do with the drugs that are part of the old longer regimen? We've seen that happen before, where we had to dispose of a lot of injectables. But of course, we had to do it because the trade-off or the difference was quite large between using 9 months with injectable and using 9 months without injectable. The benefit to patient is quite very different, and we had to do that. But if you're looking, for example, at a 9-month oral regimen versus a 4-month oral regimen, so you could make a case that with equal effectivity, then we may have the option to use still the 9-month all oral regimen. So I think that's one of the barriers or concern that most programs will have, what to do with our current stocks. And maybe this will be a good start to begin discussions on this. Will there be flexibility, for example, from the suppliers, including GDF as our main supplier of second-line drugs? Will there be flexibility? If we have already placed orders for the old regimen, maybe there is some flexibility to shift that to the newer drugs. So, and then a second concern, this is when governments start to procure drugs for the new regimen, would always be local registration of the new drugs. For example, in our case, we do have rifampicin already registered. That's a good development, but we do not have yet predominant registered in our country. So when there is already an opportunity for government to procure these new drugs, that will be a prerequisite. So I think those are just some of the concerns that we have to look out for, and we have to plan well in order to transition smoothly and rapidly. Back to you, Mike.
Great. Drug stocks gets to something that Kate O'Brien put into the chat to hear more about the 5 S's. I would say that things like drugs, commodities, or some of the stuff, which is one of the S's. I want to stick with you, Ronald, for a minute, because I think this point about what to do with old drug stocks, things you've already ordered and have in like a central warehouse or on a clinic shelf, is really important. And as you said, when we first moved to all oral treatment for drug-resistant TB, something some of our countries are still trying to fully transition to, we did have a lot of injectables lying around. These injectables that Ani in the chat calls very, very unforgettable because they were very toxic and painful. What gave you the courage? Because I do think it took some courage to get rid of the injectables without using them. I mean, we hear this a lot from countries. Are we allowed to just put these things in the trash? You know, it's, as an activist, you say, yeah, throw them out. But as a government, someone has paid for that. It's come from a public budget. It's not as easy as it might sound. So what gave you the courage in the Philippines to get rid of the injectables and move to all oral?
Yeah. Well, firstly, was the demand really. We do have an active civil society and patient group movement that are actively participating in the program. So they are involved in decision making. And of course, when they advocate and demand for it, that's one motivation or pressure for the government. But then another factor, and I have to be honest about this, most of our injectables then were really global fund procured. So there is that discussion with global fund, and we can afford to be more flexible. No? But to be honest, if it were government procured injectables, that would probably have more resistance or more reservation to just dispose of it, because of course government funding and budget tends to be more rigid in terms of the auditing, and so you needed to have a good justification to do it. But I think in the end, it's really the patient interest that has to come as primary over all these other concerns. But that would really need political will.
So that mobilizing that patient voice, something Goodman and Curie talked about, I think is a central aspect of any successful campaign in TB, and certainly this one. So our last panelist is Michael, and before I introduce him and ask him his question, just to say to you all, start putting your questions in the chat or thinking of questions that you would like to ask of the panel now that we've introduced everybody, and we can have a kind of more open discussion following. Michael, you are the technical advisor for TB service delivery supporting the Kamosha TB program in Kenya. You're a public health clinical specialist, over 14 years of experience in TB, HIV, and other infectious diseases, and you've worked in policy formulation and implementation. So really eager to get your perspective as well, kind of from the programmatic and the delivery side about 1, 4, and 6. Are there any barriers in addition to those that Ronald mentioned from a program perspective that you think we need to focus on in the early days of the campaign and come up with solutions for? Over to you.
Thank you very much, Mike. From a policy perspective, some of my colleagues have mentioned, one of the things that you look at from a policy element of it is that you have to consider the panel of experts that you have in country. Those panel of experts have to be convinced beyond a doubt that whatever is being introduced like now, the shorter regimen, they will actually work. So if I take the case of Kenya, for example, we are looking at the shorter regimen for drug-sensitive TB, where you have moxifloxacin, rivaroxaban. The challenge with that for our country is looking at what do we treat drug-resistant TB with for children, and one of the core drugs for that is moxifloxacin. So now the question now becomes, with the current trends of TB that you're looking at in our country for DRTB, for example, we are looking at an increased caseload of DRTB cases between an array between isoniazid monoresistance versus rifampicin resistant TB, which is treated normally with moxifloxacin for children. So if you consider now that, then now it becomes from a policy perspective. Now you want to convince the panel of experts, you want to introduce a shorter regimen. Yes, the benefit for the patient is actually visible, but the other question is, if you get resistant to monofloxacin, are you going to go treat it as pre-XDR, for example? Now, those are the questions that now from a panel in country we have to grapple with and find the best way possible for the patients that we serve in our country. Yes, the drugs are good. They will reduce the time spent on treatment, because, you know, if you take drugs for a very long time, if the treatment is long, then the challenges become that patients get fatigued, and there's some who end up interrupting treatment. So those are the things that we have to grapple with. Then the other element from a country perspective is looking at the cost of procurement. For Kenya, for example, I will say for drug-resistant TB, for instance, the procurement is normally done through donor funding, mainly through Global Fund. And we have also an element that is also coming through, like for riverpainting, the support has come through CHAI, that is a Clinton Health Foundation. So if you look at now those elements, the government has to grapple, where do I get these resources from? Case in point, for our country, TB treatment, it does not matter what type of TB a patient has, be it drug-sensitive, drug-resistant TB, extremely drug-resistant TB. The thing is, for the extensive drug-resistant TB, all forms of TB is free treatment. So the only thing the patient comes to get is medication. And even the investigation themselves, the bulk of them is actually footed by the government. So if I take the cost of treating drug-resistant TB currently at around 2.5 million to 3 million per patient, then that's now the question that the government has to ask itself. While looking at the shorter for drug-sensitive TB, the government foots that bill. So now that's the balancing act that we'll have to look at from a policy perspective to ensure that we're able to do programmatic implementation. If ratified, then you're looking at convincing the healthcare workers that this is going to work, and this is now looking at trainings. And those trainings also cost a bit of money, but we can be able to work around it. And then also looking at the timing, where did, looking at like now, for example, for our country, Kenya, we just revised our guidelines both for drug-sensitive TB and for drug-resistant TB. Now, do we have to go back again? Because I know from a WHO recommendation, one of the key findings was that we need to look at the shorter regimen for both drug-sensitive TB and drug-resistant TB. So now, do we go back again to revise? Because ideally, we're supposed to do that every 2 years. But the rate at which now we're looking at the recommendations are coming fast and furious. Now, it means some elements of our guidelines have to stay on ice because of changes happening, but that also affects programmatic implementation. So we have to do the best we can. Because right now I know, if I look at drug-resistant TB, we have around 18 months of injection-free regimen in terms of treatment. We haven't even gone to the 9-month yet, and now we are looking at 6 months of a shorter regimen. Now, those are the things. We've already graduated to look at the 1 month riverpainting. Right now, we are doing 3 months, 3 HP. So now, those are the elements that you're looking at. If I look at the target population again, the acceptability, and that is now where, when I listen to the survivors that we have on the panelists, the one thing I do agree is advocacy is critical for acceptance, especially where we're looking at sorting out latent TB infection. So that element of it has to begin, and it begins with the healthcare workers. Like for our country right now, we're doing healthcare worker-driven 3 HP campaigns, where the healthcare workers first are the ones on the forefront to taking it, so that they understand what the patient goes through, and with that, then they can be able to craft good messages to that would benefit the patient in terms of convincing them to actually take up this for prevention of TB disease in the future. So those are the things, and now that we are looking at convincing this array of stakeholders to actually agree with us. You know, we are doing this for the best of our patients. And if we do that, then the one thing that I know from a client perspective, our clients will appreciate, because if you have a healthcare worker who has actually taken, say, TPT, for example, then they understand the price in which you're going to go through when you're taking it as a client. So that thing is critical for us to actually work. Back to you. Thank you.
Yeah, you're talking about building consensus among these expert panels that are asked to evaluate new guidelines, new evidence, but also among a bigger community. So yes, and as you said, things are coming fast and furious now. This is a good problem to have, but it is something we're going to have to figure out, which is how do we do more frequent guideline updates, program changes? How do we replenish our drugs with new, better ones? How do we re-educate communities? How do we redesign systems for new regimens that may look really different? And we have a lot of precedent here, I think, to draw on, right? Like in our companion field, and some of you have experience working in HIV programs, including you, Michael, you know, guidelines have been updated on a pretty fast clip, you know, over time, right? Like, so we can do this. There are models for doing it. It's just that we're not maybe exercising that muscle ourselves in TB. So let's go to other questions that people have. Keep putting your questions in the chat, or if you would like to just come off mute and ask a question, raise your hand and I'll call on you to do that. But let me, while people are thinking about that, take some of the points that have been put in the chat here. There are a couple comments about phasing out old things for new ones. So Stephanie Seidel is asking, are there incentives to phase out old medicines that could be accessed through, for example, Global Fund? And to that point, one of those things we're trying to phase out is what Pumeza is calling out, the injectables. You know, are there countries that are still using them? And if yes, why? I think it may be because some of what Ronald talked about, the difficulty of, you know, trashing something that somebody somewhere in the government has paid for and forecasted and planned around. But it's not just the injectables that need to be phased out. Madhu is making the point that it's also smears, how we diagnose TB, right? Like, to be on treatment, you have to get a diagnosis, and that diagnosis has to be accurate and timely. And so we need to replace smear with molecular diagnostics, things like Gene Expert and what will follow. And I think that's a really important point. So do any of our panelists have any reflections on how to make change, how to phase out old things with new things? Or are there other things that you want to see phased out? I'll wait to see if anyone on the panel wants to pick that up, and then Robin will come to your question. What else would you get? Another way of asking the question, I guess, is what else would you get rid of in TB if you could, other than the injectables? And maybe with the silence, Ronald, your hand. Good, I was going to call on you anyway. Go ahead.
Yeah, thank you, Mike. I think another, it's not just about the stuff, as you call it, not just about the commodities, but also in how we care and manage patients. For example, it took quite a while, but we have a long history of very strict directly observed treatment, or DOT, where the patient has to really be in front of a health worker when they take the meds. And this is also a barrier for some patients to receive the treatment. So I think it's not just the commodities, the new drugs, the new technologies, but also how we provide care. And it's good that patient-centered care or people-centered care is now included in most of the NTP policies, because I think these new ways of case holding and treatment adherence, like providing more education and counseling, and even digital adherence tools as opposed to going daily to the facility. I think these are also other ways of doing things that are new and I think more beneficial and provide better results.
And maybe I'll jump the line of hands to maybe ask Tina. Oh, Tina, I saw your hand up and then you put it down. I was going to call on you because this is Tina Shaw. Let me introduce her for those who don't know. She is also a member of We Are TB and the CRAG, that group that Goodman is also on. So I know Tina through that way. And I know you have some thoughts on DOT. So I was wondering if that's what you wanted to pick up on, the care aspect. But
yeah,
also
so Ronald kind of hit the nail on the head, and I'll speak from a survivor perspective. I mean, I would love to see, for countries that have the capability to phase out in-person DOT for patients that really don't need it. You know, there's a lot of, now with the pandemic, we've been able to do a lot of electronic stuff. So I would like to see like eDOT or video DOT become the norm for, I mean, the majority of patients will be fine on those kinds of, monitoring. And for those of you that don't know, I mean, I did go through a year of in-person treatment while I was in my first year of college. So it's pretty invasive for, you know, somebody that's like 18 years old and having to meet a DOT worker every single day. I think that meeting patients where they are is really important in the treatment of patients. And as we think more about patient-centered care, that piece can't be lost of, you know, yes, they're shorter regimens, but are we meeting patients where they are to make sure that they want to even embrace this regimen?
Great point. All right, I'm going to go to you, Maggie, next, because I have a feeling you may build on what Tina says. And then we'll take Michael if you had an answer to this question. And then you, Robin. Sorry, Robin, we're putting you further down the queue, but go ahead, Maggie.
All right, I agree with Tina, because TB disease, and especially some long-term disease, the process of healing is not only physical, to be honest. And there is something I realize here, especially here in the United States. Some healthcare workers are not really trained to take care of the mental health of their patient, because it takes medicine to heal your body, but it takes a lot of care, a lot of commitment, deep commitment to heal someone and to enable someone to understand what's going on around him, enable someone to understand that, yeah, the depression you're going through right now, it's just going to pass. I am with you. So people are a lot of kind of task oriented and kind of just put aside that thing, because at the beginning, tuberculosis is kind of like a stigmatized disease. So to train TB, that is one of the things I'm kind of like speak out again and again, to train people, healthcare worker, anybody that is kind of have a one-on-one with patient, to understand the fact that it's a huge deal, and they have to understand that the fact that we go through a lot of depression, and they have to understand how to handle depression, how to handle mental illness. I went through that, not only because I have like a tuberculosis, but dealing with like an autoimmune disease on top of that, and be isolated for so long and going through long therapy till today is not that fun. So my doctor, I become like my friend, because they knew that in order for those medications to work, they need to step in and be the be the therapist, help me go out, just go beyond my comfort zone. So this is one of the things that I think the civil society and the government should really align and make sure that is a priority. And we see that with COVID-19, how COVID-19 kind of have its toll on family through mental challenges. So, yeah.
Yeah. TB healing is more than just physical. I think, we mentioned Dr. Paul Farmer earlier as kind of giving us some inspiration for this campaign. And I think what you described, he would use the word accompaniment. That was a word he liked. It's not just about giving treatment, but about accompanying the person through their treatment and offering them more than medicine. And so along these lines, I wanted to acknowledge a comment put in the chat by Vanessa Gutierrez, who talked about the importance of also bringing in Indigenous communities. And I think the point here in relation to what Maggie said, as I see it, is sort of, you have to understand the world from which your person with TB is coming from and what's meaningful to them, and meet them in that place and acknowledge that worldview as the basis for the healing that you want to do together as doctor and patient within a health system, within a program. So it's great to have that perspective. Okay, Robin, I want to get to your question before we run out of time, so I'm going to let you ask it, and then we'll return to the hands that are up and continue the discussion, but go ahead.
Thanks, Mike, and hi, everyone. Good to be with you today. Yeah, so this campaign, we're going to have a lot of targets of our advocacy, some national level targets, national TB programs, probably the Global Fund as a target, product developers as a target. And I'm curious to hear from the panelists and maybe others on this call, what advocacy efforts are underway right now? Like, are there any specific asks out there already? What's working, what's not working? Any insight into what's already kind of happening in this advocacy space would be really great to hear about. And then Mike, your vision for how to roll this campaign out with the diversity of actors that are maybe on this call today. A little bit more information on that would be awesome.
Great question. I will defer my comments so that till the end a bit, so others can jump in here. So if you have ideas for advocacy, or if you want to describe an advocacy effort related to 146 already underway, either put your hand up or put it in the chat and we can start collecting it there. And in the meantime, Michael, back to you to kind of add your thoughts to this discussion we're having, and then we'll go to Goodman.
Thank you. First, let me start with the question that was just being asked in terms of advocacy. So in our country, one of the things that we did.
Michael, for me, it's a little hard to hear you. I wonder if you can.
Can you hear me now?
Yeah, much better. Thanks.
Much better. Okay. Now, from a country perspective, one of the things that we've done from an advocacy element was to engage communities that have been affected by TB, as well as persons who are currently on treatment for TB. And the other thing is looking also for TB champions in the same communities. What this has had is the effects of also being able to rope in healthcare workers in relation more so to TPT, the 3HP that we have in our country. That element has really helped because it has improved the uptake of TPT more so for the healthcare workers. And this forms the basis for rollout to the target populations that we are looking at in our country, like persons living with HIV, those people who are incarcerated in our prisons, that group, and those others who are at risk. That way, then the healthcare worker is the one at the forefront of advocating for TB preventive therapy. Then the other thing that we're also looking at is that from an in-country perspective, we've tried to increase our budgetary allocations from partners also within government as well for advocacy elements. And this is critical because we know any public health interventions requires considerable investments in advocacy, communication, and social mobilization for purposes of engaging and ensuring that the public health intervention that we want is able to be taken in the perspective that it needs to be, in the positive light, and that then becomes acceptable. If we do this deliberately, and of which in the TB world we have started doing this, and we invest more, then I believe the TB champions, the TB survivors that we have, as well as the TB affected communities and the healthcare workers as well, will be able to contribute meaningfully for the purposes of ending TB globally as is. Then the other thing that I also wanted to look at here is we also have to think about the element of post-TB treatment surveillance, because there's some patients who have post-TB treatment complications or post-TB disease complications after the treatment of TB. This is an element that we have not really invested in and we will require to invest substantially. Case in point is the time, I think in 2008, I had an MDR patient who had a collapsed lung. But because he did not have the resources necessary, we couldn't do a lobectomy to just remove the collapsed lung from him and just leave him with one lung. And the other thing that unfortunately that happened is that when he got a chest infection, he unfortunately died from that chest infection. Why? Because the healthcare workers, they did not have the knowledge or the capacity to manage this client. So when I'm looking at it now from that perspective, there's more that we need to invest in post-TB treatment surveillance, post-TB disease surveillance for purposes of equipping our healthcare workers to look at post-TB disease complications. And this way then we'll have been able to improve the quality of life of those who have been affected by TB directly, and also take care of the needs of those who also take care of them. Then lastly, let us look at the catastrophic costs that come about because of daily observed treatment, for example. Can we think about what we do in HIV, differentiated service delivery in the community? And that is now where the new technologies are looking at video dots, where I look at DAT, digital adherence technologies. That is now where they come in. And can we also capacity build the community to also help us with differentiated service delivery for TB in the community? If we do that, then it will actually benefit us. From a country perspective, we did that for drug sensitive TB, but for drug resistant TB, we've been unable to do that. We're still stuck on daily observed treatment because of the number of drug-resistant TB cases that we have in the country. Back to you, Mike.
Thank you. Yeah, I'm so glad you brought up those points about post-TB and what we call DSD, differentiated service delivery, kind of a technical term, but a really exciting set of ideas. Madhu, and then Goodman, I know your hand was up, so we'll come back to you if you want to say something, but Madhu, since you're currently raising your hand, over to you.
Thanks, everyone. Such an important campaign. It's a no-brainer campaign. And there isn't a single person alive who will say, I'll happily take a 24-month regimen if I can take a 6-month one, right? But we know from history that the TB field is very refractory even to no-brainer issues. Okay? What you and I would have thought was absolutely a no-brainer, we are still waiting for it to happen in TB field. So we should never assume that things will just happen. We have to make them happen. And making them happen in this case, I would argue, every single TB survivor advocacy civil society group must get behind this campaign, because that has to be the engine around which the rest of us who are not TB survivors will show up as allies and support. So to that extent, I'm thrilled to see, several TB survivors here. As many of those groups, if we can get them on a Zoom call, go through a similar process and then say, what is it that is necessary for, 25 civil society TB survivor groups around the world to unify and get behind this would be extraordinarily powerful. I also put a comment in the chat box. Kill injectables seems like a very, very sharply focused campaign, but I don't know enough to say, will killing injectables automatically ensure uptake of 6-month all oral? If yes, then I would say it's something that we can all rally behind very quickly. Just go all out on a blitz. We do not want to see injectables anywhere in the world for anybody with TB, drug-resistant TB, and it's a very sharp discussion point. And then lastly, this came up at our Montreal launch event. I'm already hearing people expressing concerns that shorter regimens will bust the bank for national TB programs. And the arguments that all of you made early on, that having 18 months less of treatment, how beneficial is that for the person, right? How soon can they get back to join workforce? How soon can not having to deal with toxic effects mean for? So we need a strong argument that the actual cost of the pills is not the driver. The total savings that we will make by all the person years of suffering that we will reduce, and all of the young people getting back to work, that argument needs to be there right up front and front. Otherwise, these bean counters will hammer it down by saying, hey, look, our budget is this much. If we bought rifampicin and betaquilin, it's all gone. So we can't do anything else. And then we are dead, because we can't face those bean counters without a very powerful counter argument that the actual net savings for the country, the society, for everyone will be 1,000-fold higher, whatever we need to make. I think that will be helpful.
Yes. And we are encountering the bean counters already. And I think, sometimes they're very focused on drug costs and budget impact. And sometimes it can be uncomfortable to put a value on your life, but I think we do have to have a conversation that says, the life of the person with TB has value. Their time is valuable. Their experience is valuable. Their life after their treatment is valuable, and it's more valuable than the cost of these medicines, and that's sort of the point that Maggie was making at the beginning when you brought up cost effectiveness. Okay, Goodman, we have about 5 minutes left. So over to you for one of our last comments, and then I'll wrap up and hand back to Petra.
Okay, thank you very much. I will just talk with Maggie, and the question was what we can bring, what we can move out like injectable. But one thing we forget, the stigma, it's always there. What can we do we bring this new regimen to the community, but the stigma still around them. I was doing with Pumeza a survey in the community to find out exactly what else they need to to finish their treatment. And the gap is the counseling, because we never have a counseling during this period. So they need someone to have a room where they can talk to, as Mekisho was mentioning, to create a relationship with your doctor, so it can be easy. It won't work for me too, but it won't work for everybody. So what can we bring on this regimen? It's not only about the medication. It must be also a support system. As you can do the counseling, you know, you have room for that is opened. You can go anytime when you're finding difficulties with the treatment. But after that, when we're doing this campaign for shorter regimen, we should be also involving the stigma to community, so they can know TB is a normal disease like any disease, like diabetic, like high blood pressure, because people, they end up losing hope through of the stigma in a community, through of the stigma in the clinic. Now we are lucky enough because we did have a COVID. So on that period, they didn't know who have TB or the RTP, because we're wearing all of us a mask. But now it's now more COVID in South Africa wearing a mask. Now we're stuck with this green mask we must wear in the trip. So that is also bringing stigma. We bring the medication, but our room are not clean. We should be clean. Our room, educate our community, educate our healthcare facility, educate our patient, and we support them. Thank you.
It's a great note to end on. And Robin, to go back to your question, sort of what's the vision of the campaign? I like kind of the idea that's come up out of this session that Madhu and Goodman just expressed, which is, I think people who have survived tuberculosis or been affected by it really need to be at the heart of where we go from here in driving the campaign. And I should just say, from Treatment Action Group's perspective, we don't feel proprietary over 146 by 24 as a slogan, right? Like, if you are connected to a network and you want to say we're working on 146, go work on 146 and say that you're doing it. You don't need our permission or anyone's permission to do it. We're kind of trying to create an organizing umbrella under which all of our efforts can be directed toward a common goal of making shorter treatment available. And in doing so, work on the staff, the stuff, the space, the support, the systems, overcoming stigma. Maybe we'll have a kind of 6S about stigma being overcome. That would be a nice addition, I think. And so let's think about how we go from here. This was the TBPPM Learning Network. So we had a chance to bring together survivors and practitioners, including some from the private sector. We didn't talk a lot today about private versus public sector. I think we're going to have that conversation too, right? Our private sector providers don't always have access to the new tools, actually. Sometimes they struggle to get the stuff that they need to make regimens available to their patients, or they're left out of certain systems. We need to bring them along as well. And so, Petra, maybe I'll turn back to you, but also kind of throw the question to you, like, where do we go from here? And what's the role of this network in taking us there? And just to say a final thank you to the panel and everyone who participated. This was really great.
Thank you, Mike, for moderating, and thanks everyone for incredibly useful thoughts. I do feel this is the start of a conversation. So, Mike, thank you for bringing it forward, and all the panelists. I want to thank everyone. One way forward, as you said, kind of this is, we didn't get to the heart of the TBPPM learning network of the private providers. So why don't we just say, let's take another discussion on this topic where we specifically talk about the private provider side. But to wrap this discussion up, because I feel even where we've started now, with where we talked about a lot of the demand and the education, but we also hinted towards the 5 S's, the supply and that side, which is much more on the program side, and Alan and Michael gave some really good input on that. I think both of those elements are important when we talk about advocacy campaigns. So I would like to suggest that we, in the Learning Network as our team, we kind of wrap this up in a report, which is not necessarily a report, but we'll make it into an op-ed, and we'll send it to some of you who have given quotes, and anyone who would like to be part of it, please send us suggestions. We will send a draft around so that we have a joint kind of statement as a first conversation piece that we agree to, because I really agree that TB survivor voices are crucial to carry this. So I don't want it to be seen as a TBPPM Learning Network report from a forum, but I would like to see this the voices of everyone who was around the table today. So that's my first suggestion as a concrete next step. And I also want to say that a second forum specifically on private providers is absolutely a possibility if people are interested. We're also thinking about a webinar, which we're planning actually already, on post-lung disease. So this is the topic that came up today as well, and we very much love you all to participate in that. So there is more coming from the Learning Network side. Please stay in touch. We will reach out to everyone who is on here. We have you registered, so that will be our promise and follow up. Know that this is recorded, so it's on YouTube. If you want to share it with anyone, please do. Please reach out to us if you have any concrete thoughts, or if you're doing advocacy campaigns in the broader sense. I'm sure Mike is also open to hear from you directly, but this is something that we want to make really a large campaign. So feel free to put your voices and hands up with ideas, and we can brainstorm further, either individually as a group. Thanks, everyone. This was a wonderful, wonderful discussion. And have a great rest of the Friday evening, night, or a good weekend to anyone on the call. Talk to you soon. Thanks so much for joining.
Thanks, Petra. Thanks, Joel. Bye, everyone.
Thanks, everyone. Bye.
Bye, everyone.
Thank you. Bye, everyone.